Well, welcome everyone. For those of you on Zoom and for those here in Los Angeles, we're happy to have you with us. And this is our Race to Erase Forum. I'm Claudia Curry-Hill, your moderator for today's panel, and I have lived with MS for 40 years myself. So these are our Center Without Walls doctors, and the Center Without Walls program is funded by the Race to Erase MS and has provided support and has permitted the medical community to link together multidisciplinary scientific programs and expertise across the country to advance the understanding of the cause of MS and to develop new treatments. The center is a breakthrough success because of the vision, insight, and flexibility of these extraordinary doctors today. So I'd like to introduce Dr. Liliana Amezcua from USC, Dr. Peter Calabrese from Johns Hopkins, who's joined us on Zoom, Dr. Charles Goodman from Harvard, Dr. David Hafler from Yale, also joining us via Zoom, Dr. Adam Kaplan, president from pharmaceutical and adjunct family faculty from Johns Hopkins, Dr. Nancy Sykott from Cedars-Sinai, Dr. Vijay Yadav from Oregon Health Sciences Center, and Dr. Scott Zamville from USCF. Also, Nancy Davis, founder of the Race to Erase MS, dedicated philanthropist, jewelry and clothing designer, and devoted wife and mother of 5. It is my pleasure to introduce our founder, Nancy Davis, to kick off our panel discussions today.
Thank you so much. It's such an honor to be here with this beautiful audience, this esteemed group of research scientists who are truly the best in the entire world, planet, and all of that. My journey, very quickly with MS, I was diagnosed 31.5 years ago. And at the time, there was no known cause, no cure, no drugs on the market, and very little hope that there would ever be anything on the market to help stop the progression of MS. I was scared. The first doctor told me that I should just go home and go to bed. And I said, for how long? A week? What do I do? He goes, no, for forever. I'm like, what do you mean forever? I'm 33 years old. I have a lot of life left to live. And it was pretty devastating. He told me that I was lucky that I would be able to operate the remote control in my TV set and probably watch soap operas all day, which wasn't something I really wanted to ever do. And he was telling me I was lucky so I could have people bring me food in my room. And I started thinking, God, a day ago, I was a full-time mom and had lots of dreams and hopes and wishes. And, I have something called spilkas. I don't know if you know what that is, but I just have to do something all the time. I have to be busy. And the idea of being reduced to a life doing nothing didn't sit well. I was lucky that I could go get second opinions, which I know a lot of people don't, but everybody should always get a second opinion because you will always hear something different than you heard from the first doctor, no matter who it is, no matter how great they are. There's always different things that you get from every opinion. I went to get second opinions because I was praying that someone would say I did not have MS. Unfortunately, everybody said I had MS. My MRIs were pretty compelling, and whatever it was, I had MS. However, as I went from doctor to doctor, it was interesting how the prognosis varied from doctor to doctor. And whereas the first doctor gave me no hope that I would ever, amount to anything or do anything in my life, some other doctors said I could have a good quality of life. And I chose to listen to every positive note and message that I got. But along the way, in talking to some of the best doctors in the country, I learned when I asked about the research that they were doing, the most brilliant doctors from all these great places, a lot of the doctors were doing identical research as each other. And we're pretty much working in a vacuum, and we're not aware that every other doctor was doing the identical studies that they were doing. And so that light bulb went off in my head. And I thought if I could put the best and the brightest to work together as a team, a dream team per se, we would find a cure a lot quicker for MS. So cut to the chase, here we are today. I'm lucky to be amongst this group of most, brilliant doctors who have spent their life doing everything they can to find cures for MS. The exciting news is we just had our 30th Race to Erase MS in June, and there are now 25 drugs on the market to help stop the progression of MS. That is nothing short of a miracle. And I have every one of these doctors and every one of our supporters and everybody to thank for this miracle happening and changing the lives of everybody who lives with MS. So thank you all for being here. Thank you for devoting your lives, because it means everything to me and everything to everybody here as well. So how do we find a cure? That is my mission. I'm going to make sure we find a cure no matter what. I'm very driven, and I don't take no ever for an answer for anything. I just don't believe in that unless we have the perfect answer. So I'm so glad to be here today. There's so many new things, so much new innovation. Race to Erase MS is funding a lot of really amazing research. And there's so many different aspects to MS, different symptoms of MS, different things that bother you. We're so lucky that the B-cell therapy drugs are really helping such a huge amount of people. And listening to the meetings with all the doctors yesterday, there's not the amount of relapses that there used to constantly be. So that's kind of brilliant and fabulous. However, there's other things, and some of those medications aren't great for every single person. So we're trying to create different things. And one of the big things that we're really trying to do is figure out how to remyelinate. That seems to be the biggest thing that's eluding everybody. If you've lost myelin and certain functions with that, how do you gain it back? So we're on a mission to solve that, and many other things, making it more affordable to be able to take care of your MS, and making sure insurance companies are covering things that they should cover. And there's so many things, but we always want to hear from you and what you think we could do better, and how we could be better. So that's our real mission. So without further ado, I'm going to go to the real science minds here, and they're going to tell you about the brilliant research that's going on. But thank you all for your support. And on May 10th, everybody should come for Race to Erase MS. It'll be our 31st Race to Erase MS, and it will be spectacular and memorable. So you have to come.
Thank you, Nancy. So our first topic today is new drugs to prevent relapse, including BTKI. Dr. Scott Zambo.
Great. Welcome. I'm excited to be here and to present at this meeting. I must say that I find it even more rewarding speaking to patients than my fellow neurologists. It's always challenging for us to handle some of your difficult questions, and we encourage that. I also welcome the over 100 patients that are on Zoom as well. So my task today was to talk about BTK inhibitors in relapse and other therapies. I'm going to focus on BTK inhibitors for a very short time, and then talk about cellular immunotherapy, which is a direction that's emerging and eventually will be with us. So a futuristic therapy. And the BTK inhibitors, it says relapse, and that was the goal here. But really, we have really potent drugs right now with the B-cell depleting agents. We have the natalizumab or Tysabri. These are very effective on relapse. And what we have and we know is our unmet need, as we say, is progressive MS, both secondary and primary progressive MS. And in general, the therapies, when they emerge and go through trials, they do go through the pathway of relapsing remitting MS until we had our first B-cell depleting therapy, which was tested in both relapsing and progressive MS. So we are really working hard on progression. The BTK inhibitors, there's a lot of buzz because in the next year and a half, we'll be hearing about those medications. They're oral medications. Some are taken once a day, some twice a day. The medications, we say Bruton's tyrosine kinase inhibitor, and that was because a long time ago, somebody by the name of Bruton had discovered this enzyme in B lymphocytes. And as you know, there's two flavors of lymphocytes, B and T. I'm more of a T cell minded person, but I do work on B cells in my research funded by the Nancy Davis Foundation. But in Race to Race MS, the B cell is one target for the BTK inhibitors. And that's important in terms of relapse and remitting MS. But the BTK, the Bruton's tyrosine kinase, is also found in other cell types in the immune system that may play a role in progression, which is microglia, macrophages in the central nervous system. So the interest and in the clinical trials, and there are so many different ones that are being tested, 5 currently or should be reading out in the next year and a half or so. Those medications, they have different levels of effect. They're a little bit different in their specificities for this enzyme, but they may have a role in progression, and that's where I think we want to watch them. The phase 2 trials have shown just recently, one of them, fenebrutinib, was presented in the big meeting in Milan. It was very effective and reduced new inflammatory lesions by nearly 90%. We do want to see how they affect in terms of progression. We also are concerned that some of them have some liver toxicity. So I would say I have a moderate level of enthusiasm. I don't want to see these medications, each one derailed because of the toxicity. Some may have less. And I think that some they may have different activity than B cell depletion. So I would not want to say if they are not as effective as B cell depletion, they may be important. You'll be hearing more about them. And I would also like to switch gears just for a minute and talk about the cellular immunotherapies. Many people know that in oncology right now, B cell lymphoma, well, I should say even the BTK inhibitors are used in oncology first, but the cellular therapy you'll hear about in the future are the CAR T cells, the chimeric antigen receptor T cells, more of a space age therapy at this moment, but maybe not so because they're merging into phase 2 trials, phase 1 and phase 2 trials with some of the pharmaceutical companies. And these are therapies where we can target B cells and also to the brain. So these are given by infusion, and they've had a remarkable effect in B cell lymphoma, but they may work in MS as well. And the one type that I'm interested in is a 2-step one that can target to the CNS and then turn on its payload of anti-inflammatory or neuroprotective cytokines in the central nervous system. And that is, at least in animal models, is being moved forward and hopefully will be in trials fairly soon. So I'll stop there. Thank you.
Thank you, Dr. Zamba. And next, we have new drugs to slow down disease progression. Dr. Liliana Amezcua.
Great. It's really a pleasure to be here. And again, thank you, Nancy, for all your support to USC and to every institution that is here represented. It's really a pleasure to be here and talk to patients and bring you some up-to-date news. So just stepping on what Scott Zanville mentioned is to stop progression. Definitely one of the utmost unmet needs for people with MS. And but one thing to note is that there are multiple ongoing global efforts that are, taking part so we can come up with best therapies. Organizations such as the National MS Society, the MS Trust Foundation, the International Progressive MS Alliance are all working because we all know that this is the most important thing that we need to focus on for the next several years. We've done tremendous work, I think, with the disease-modifying therapies for relapse and remitting, and so now we need to focus on these populations. So currently in the market, we all know ocrelizumab is out there for primary progressive MS. We know it works better when it's early, in the disease, and where there's has some evidence probably of some activity they're noted on MRI or by clinical. There's also siponimod Mason, which, got that label for progressive MS, but really there was this active part to it. So there's progressive MS forms where there's activity. And in most cases, we always believe that a lot of the disease modifying therapies that are approved could work. But when we're talking about progressive MS, we're really now talking about those that there is no sign of inflammation, and what can we do? And a lot of the therapies that are being tested, including the BTKIs that we just heard, is with the hopes that there can be better penetration to the central nervous system and really work on those players that are perhaps influencing the CNS. So one of the ones that we're looking at and is being looked at is a lot of the repurposed drugs. Repurposed drugs are drugs that are available that are used for other conditions. For example, metformin is being looked at as a therapy in progressive MS. It is being looked at also at the same time with other therapies. One of the trials is called Octopus trial, which is based at from the UK. And individuals with progressive MS can go on this trial, and they'll either be, sort of stratified to one of these repurposed drugs, and then they're given the opportunity to go into another drug, which is another, could be another oral medication. So metformin, one of the thoughts is that it works in trying to reverse some of that aging-related problems with remyelination. There is also a small trial that I believe is supported by the Nancy Davis at UCLA looking at metformin. I don't remember if it's for progressive or just MS in general. There's also ibutolast that is being tested, which has been shown to have some effect in brain atrophy measures. So a lot of the measures that we look for in progressive MS is looking at that brain atrophy, neurodegenerative aspects of the disease. There's also clemistine, which is a drug that's available as an antihistamine used in hay fever. That's also been shown to have some properties to slow down the progression. Of course, we have lipoic acid, this is a strong antioxidant, and a lot of that work comes from OSU, which has shown to have some effect by reducing brain atrophy by 68% compared to placebo. So really exciting news about these studies. Of course, a lot of them are still needing to go into that final phase to really show us if they're going to work. There's also a really exciting anti-CD3 therapy that's being tested at Harvard, where the drug is being given intranasally, and it appears to be quite effective in slowing progression. Of course, this is very early on, phase 1, going into phase 2, but has an effect, I believe, in T regulatory cells. So really exciting times for progressive MS, and really also there's some therapies also looking into neural stem cells very early on, again, in the progressive forms of MS.
Thank you, Dr. Amastua. And next we have new immunology updates in MS, including mesenchymal stem cells. Dr. David Hafler from Yale.
He's on mute.
He's on mute.
David, I think you're on mute.
I was on mute. Okay. They muted me. Okay. So in terms of immunological updates, first, let me apologize for not being there today. Something came up personally that allowed me to do this. So there's been the tremendous advances in the immunologic understanding of multiple sclerosis. And we start by saying that B-cell therapy, having been in the field for 40 years, and remembering when I first saw my MS patients back in the 70s, indeed, we said, go home, there's nothing we can do. And now we have therapies that can stop early relapsing-remitting disease over 98% of the time. Very different from progressive disease, which remains a major issue for us to better understand. But getting back to what causes multiple sclerosis, we've been examining with a grant from the Nancy Davis Center Without Walls, precisely how does B-cell depletion work. And by manipulating the immune system and seeing a very positive effect, gives us great insight into what causes the disease. And what we discovered is that there's a type of cell in the spinal fluid and in the blood, which is an antigen-presenting cell, which appears to change with treatment. It goes up markedly in frequency, and it develops the expression of a particular type of cytokine called TNF. And what we found is that this expression of TNF directly induces regulatory T cells. Now, what are regulatory T cells? What happens in multiple sclerosis, it's an autoimmune disease where the T cells are attacking the myelin. What leads to this happening? Well, there's a genetic basis for the disease, but more importantly, the genetics leads to a loss of immune function, a loss of these regulatory T cells. And it appears that by doing B-cell depletion, you're inducing these antigen-presenting cells to induce regulatory T cells. And that leads to a marked loss of autoreactive T cells. So to me, we're gaining tremendous insight into the causes of multiple sclerosis by doing these manipulations. Again, I thank Nancy Davis, the foundation for the support of this work. Let me just point out some very recent work published in the journal Nature a few weeks ago. We talked briefly about the genetics. So MS is caused by hundreds of common genetic variants, all good variants that fight off infection and fight off cancer. But too much of a good thing can become a bad thing, and too many of these good variants lead to an overactive immune system. And we've been able to map those genes, and we know what they are, and they're predominantly immunologic genes. But what about progression? What are the genetics of progression? And what we recently discovered, part of the International MS Genetics Consortium, is that progression is linked to a different set of genes, of common genetic variants. And these genetic variants are not immunologic, but are neurologic variants, which lead to progression. So what we're learning is the genetic variants, which lead to induction of MS with the loss of tolerance, so the T cells attack the brain, are very different than the genetic variants or genes that lead to progression, which are not surprisingly neurologic genes. I think those are the two major points I wanted to make related to discoveries related to the immunology of multiple sclerosis. So I think I'll stop there.
Physical and cognitive rehabilitation. Dr. Vijay Yadav.
Thank you, Claudia. And first of all, I think I would like to begin by thanking Nancy, you for your vision that you bring all of us together, like, twice a year here, and make us available to the patients who actually really need this kind of information on a very timely manner, because the field is changing so rapidly. So thank you for that opportunity and for us to be able to share the knowledge with the public. In terms of the MS advances, I think all of us have heard we have made huge advances in relapsing diseases, and we are able to control the disease activity quite effectively. But there are still many, many patients who have sort of ongoing issues, which are a result of the damage that have already incurred, and that is somewhat permanent, or it's quite disabling. So that is not affected by the disease-modifying therapy. So those symptoms that patients suffer from, for example, like mobility issues or fatigue issues or cognitive impairment issues, those are really critical for patients' quality of life. In the past, we used to say, with MS, you should not be exercising or you should be resting, like what Nancy was saying, when there was no therapy, just rest because you're fatigued. That's not at all the case anymore. So one has to remember, even though you have MS, there is no exercise limitation or there's no physical activity limitation for you. Whatever you can do in your capacity should be done and should be encouraged to be done by anybody. If you have limitations, or if people have limitations, they should be working with the rehabilitation folks or their doctors including the primary care doctors, to enhance that capacity. So just because you have a limitation does not mean that you should be stopping, but enhance that activity. Technology has made a huge difference, I believe, in enhancing the rehab potential for our patients. So for example, now we have devices like, there's a device called WalkAid or Bioness, which is a stimulation device which can be given, it's an electrical stimulation device which can be put on the legs, and then it can enhance the walking capacity. They are not currently approved by the insurance companies many times, but they are available. So working with a therapist can be extremely helpful in making sure that you have access to those devices. In general, exercise should be done minimum 3 to 5 times a week. And these are not, I'm not just making it up. These are like proven recommendations from experts who have been working in this field for many, many years. And they're really proven to show that exercise helps patients with MS. See, one important thing to remember is cardiovascular health is super important for everybody with any disease, healthy state including. So if you do not really have the cardiovascular health, which exercise is one of the ways to improve your cardiovascular health, you will not feel good. So, having fatigue, in fact, we have very high quality research going on at our institution looking at exercise as a remyelination potential. So when you're exercising, you're actually improving the neuronal function to the point that they can actually change the neural pathways. So same thing could be true for nutrition as well, because what you eat will improve your health in general, providing the right nutrition to the healing process of the nervous system. So both, it's not just exercise alone can make changes, but if you change your overall lifestyle, including diet, all of that can make a huge difference in how you feel. So your overall quality will improve by utilizing these resources which are available to all of us. And pretty much, at least in US, I can tell you, we have access to the best system. You just need to harness that information and work with and be knowledgeable about these resources available to you. So I can talk on and on and on, but I think there are many, many things. Exercise and diet truly are I think they should be the cornerstone of healing and doing better with MS despite disability. So never undermine that power, because it truly has healing and remyelination capacity, I should say.
Thank you, Dr. Yadav. So next we have Dr. Peter Calabresi. Can we repair and replace myelin?
Good morning, everyone. I too would like to thank Nancy, as always, for bringing us together and her vision for putting the Center Without Walls together. I'd also like to thank all of you who are there in person and online, people who may have the disease or family of members of people who have the disease, and we're with you in this battle. And just want to assure you that we are making progress, especially for progressive MS, which is the essentially untreatable form of the disease. Before I tell you about updates in research, I just wanted to mention that my good colleague, Dr. Adam Kaplan, who you'll hear from later, has frequently commented on my lack of California cool style. And he, as you might see, is wearing a very cool shirt, and he's noticed that I tend to wear white or just plain blue shirts. And so last spring, he bought me a really cool shirt. And I promise you that next spring, when I come to LA, I'm going to wear a much cooler shirt than I'm wearing now on the East Coast. So thank you, Adam, and we'll see if it really happens. So can we remyelinate? Yes, I think we can. Charcot, who described the disease over 100 years ago, noticed that that there was demyelination, but that sometimes there was evidence for partial remyelination. And this has been seen over and over again. We call them shadow plaques. Maybe 10 or 20% of patients have evidence for remyelination when we look at their tissues, usually very late. Perhaps this is happening actually much more efficiently than we realize in people who are living with the disease. And this may be one explanation for why some people have relatively mild forms of the disease for 40 years, as you've heard. So how does that happen? Well, it turns out the brain is really clever. It has a kind of stem cell in the brain that we call oligodendrocyte precursor cell, or OPC for short. And the oligodendrocyte is the myelin-making cell. And these precursor cells, unlike most other brain cells, retain the capacity to divide. They can proliferate and reproduce themselves. And it turns out about over 20 years ago, neuroscientists discovered that these OPCs can turn into myelin-making cells and make new myelin, which offers great hope. And our lab and other labs have shown that in models, animal models of the disease, that these cells can be boosted to turn into more of the oligodendrocyte myelin-making cells. But the question is, why does that process fail far too often? And the answer is threefold. There are infiltrating immune cells that release inflammatory cytokines, as you heard from Dr. Zamville. And one of the canonical simple ones, it's called gamma interferon, turns out to be very inhibitory to those cells, into the myelin-making cells. So we have to figure out how to stop that. And of course, we have actually pretty good drugs to prevent the cells from activating and getting into the brain and releasing gamma interferon. So that's good. And I would encourage you to stay on maximal treatment and prevent any new lesions from forming, because that will limit the amount of demyelination and allow for possible remyelination to happen. A second block to remyelination are the brain cells themselves. And some of you have heard me talk before, mention that there are glial cells in the brain, microglia and astroglia. They got their name because people literally thought they were glue cells, kind of holding the neurons up like a skeleton. But these cells actually are very active. They have immune functions, and they can release inflammatory mediators that are actually inhibitory to remyelination. And as you heard, we are trying to develop drugs that get into the brain and target some of these cells. The BTK inhibitors actually some of them may get into the brain and target microglia in a way that could be beneficial to remyelination. So there's a lot of research going on. We're looking at the astrocytes. Dr. Voskuhl, who you're going to hear from next, is also looking at the astrocytes. There are sex effects that affect all of these pathways. And so a lot of research is being done on the brain cells. And then, as you heard from Dr. Hafler, there's probably a genetic susceptibility in some people that may be conferred by some of these glia. So in progressive MS, what they found in the Nature paper came out earlier this year was that some people may have gene variants associated with different functionalities of the glia. And then, of course, finally, you need nerve wires or axons to wrap the myelin around. If the nerve wires are entirely gone or the nerve cells die, then there's going to be nothing to put that insulation around. So that seems obvious, but of course it's a problem in MS. We know that sometimes the nerves are transected or cut, and so we have to try to prevent that from happening, not only from the very beginning with blocking the inflammation, but there are new strategies to protect nerves from dying. And a really talented MD, PhD graduate fellow in my lab presented data yesterday when we had our science seminar on a new strategy to protect neurons from dying, keeping them healthier. And therefore, perhaps the axons would stay healthier, be more receptive to remyelination. So whenever we study a pathway in MS, we never study it in isolation. We have to think always, what are the neighboring cells? How are they functioning? Can we block the immune cells from the blood from getting in? Can we turn off the angry cells and make them more what we call homeostatic and function normally and participate in the repair and recovery process? And so those are the three avenues: the peripheral immune cells, the glial cells, and protecting the neurons and axons that we're working on. And a lot of progress has been made. Again, I said this in the past, but the drugs that we have now didn't just come out of the blue in the early 90s and early part of the millennium. This was from immunology research in the 70s and 80s, so 20 years of immunology research. The good news is that a lot of the neuroscience research that has led to the targets and the pathways that we're now testing in clinical trials for neuroprotection and neurorepair are already identified, and now we can move forward with these clinical trials. But we do need to have ways of measuring whether things are working. And so there's a lot of emphasis on what are called biomarkers to see if the axons are still intact. We can measure particles that are released by damaged axons called neurofilaments. And so that's good. That will be useful. And then you're going to hear from some of our panelists about the advances in MRI, which will allow us to see if the myelin is intact or starting to be repaired, because you have to have something to measure there, right? And some of the new MRI techniques, there's something called quantitative susceptibility mapping that we're doing, a lot of people are doing, that will show us evidence about the angry glia, but also can provide evidence about the health of the myelin. So I think things are looking really promising. Never goes fast enough. We're working really hard, and we will get there. I am confident that we're going to find something. It's just taking longer than it should. And as Nancy always says, it's a race, and she inspires us to run faster as much as possible. So thanks for your attention, and look forward to the Q&A session.
New MRI markers for MS diagnosis. Dr. Nancy Sykott.
Thank you, Claudia. And I just want to say, Peter, I'm looking forward to seeing that cool outfit that you're going to be wearing next spring. And I don't know if Claudia mentioned, but Dr. Voskuil, who was scheduled next, is not able to join us today, unfortunately. So I know you were talking about referring to some of the work she's done on astrocytes, but I'm going to be talking about something a little bit different related to MRI. So you heard from Dr. Calabrese and heard from a lot of us that the last 30 years, 20 years in MS has been a sea change in terms of how we are able to diagnose and treat patients who live with MS. And I want to thank Nancy for her leadership in this area. And my career has spanned this time. And when I first started seeing patients, we had no drugs. Then we had one drug. And so we've really seen how this work, which was made possible actually by finding new biomarkers. So when you're looking at a therapy and you're trying to determine, does this work? We were really, it was really difficult and slow with MS, because if we were waiting to see changes on relapses, for example, we know how unpredictable the disease is. And sometimes it would be 3, 4, 5 years in between relapses. But when MRI started to be used and was applied to understanding MS, we learned a tremendous amount about what was actually going on in the brain and the spinal cord. And it turns out that there was a lot more MRI activity than clinical activity. And so that told us that the disease is active even if patients are not having symptoms. This is really important for us as we're thinking about the disease, but it also gave us a way to have a measure of disease activity that we could modify or see if our therapies could modify. So MRI became a really important biomarker, and all of the therapies that we have available to us now have shown effects on decreasing the numbers of these new or active lesions that we see. So now that we went into this therapeutic era, it turns out that now the stakes have changed, right? Because we have these effective therapies. And so the push became not to tell patients to go home and stay there because there was nothing to do, but we really had an increased emphasis on making a diagnosis and getting people on these therapies. And so the pendulum swung a little bit in the other direction, because we were really relying on MRI to help us make the diagnosis. And it turns out that a fair number of people, when they come to our clinics, our MS specialty clinics, with a diagnosis of MS, they actually don't have MS. And in our work that was done in our clinic with Marwa Casey, showed that almost 20% of the patients that came to us for second opinion actually didn't have multiple sclerosis. They had other conditions that gave them changes on their MRI. So this is something that is a little, because is very important, right? Because we want to make sure that people who are being put on the disease modifying therapies actually have MS. But if they have another condition, then it's really important that that's recognized as well. So we have been working with help from Nancy, really fundamentally helped us with a pilot study that we did to establish a new biomarker that has sensitivity and specificity for demyelination, and that's called the central vein sign. So part of the Race MS, which brings all our groups together, we formed an imaging consortium called NAMES, and we started out with just the race sites, but now we're up to over 35 centers across North America. So it shows that the money that you contribute and the seed funding has really blossomed. And we now have a project that involves 11 sites across the US that's funded by the National Institutes of Health to validate what's called the central vein sign. And this is something very simple, truthfully, and it goes back to Charcot. Charcot was the first one to describe MS, and he described everything about it. We always go back to him and realize, oh, he talked about that, he talked about that. But the lesions in the brain that are associated with demyelination, they start around a vein. And so now with our imaging tools, we can actually detect that vein. So we can look at the lesions and say, does it have a vein or does it not? And if it does, then it turns out it's very much specific for diagnosis of MS. So this is really helpful in identifying who has MS at the very earliest stages of the disease. And we're hopeful that this will help us to get the right people on the right therapies. And in the same time that we've been using these techniques to look for the veins, we have also found some other interesting changes within some of the lesions that we think are not only specific for MS, but might be important for prognosis. And I think you're going to hear a little bit more about this from Dr. Gutman, but it's very exciting, I think, in the world of imaging, in that we have now these new biomarkers for not only for diagnosis, but we're hearing a lot about these potential therapies for progressive MS. And in order to know if those therapies are working, we need a different set of biomarkers on imaging. And some of these newer biomarkers that Dr. Gutman's going to tell you about are probably the good targets for us to see whether or not these therapies are working. So I think it's a great time now in terms of having effective therapies, but also being able to diagnose patients effectively and early and appropriately to get them on new therapies. And I want to thank Nancy again for all her support, and to our colleagues, all of whom we're working together on this issue. So thank you.
Thank you, Dr. Saikat. And next we have imaging markers for MS progression. Dr. Charles Goodman.
Thank you very much.
If anybody has some questions afterwards, we're going to go into a sort of the quick fire round. And if anybody has questions, Dana will circulate around the room and pick up your questions. The doctors to answer.
Well, thank you very much for having me and for giving me the opportunity to speak to all of you present and on Zoom. And I wanted to really thank Nancy for giving us this opportunity, for her persistence and stamina over more than 30 years. I was here many, many years ago, and it's amazing to see what the Center Without Walls has become and continues to be. So thank you very much for all the support. My task is to talk a little bit about MRI, the role of MRI in progressive disease, markers, MRI markers or biomarkers of progression. And I want to give you a little bit more of an overview. So in a way, we are the distant cousins, or we are the Cinderellas in a way. So we're often in hiding. What really matters, as you all know, is drug discovery and applying the appropriate drug for each patient's specific condition. And we are here to support that. We are here to support it in a number of ways. First of all, MRI, but it's not just MRI, by the way. My title is imaging, and I will talk a little bit about a few techniques beyond MRI in a moment. Imaging is there to help us understand the disease in the human. So we hear about all this wonderful research that is done in animals and really has led to remarkable treatments. Imaging allows us to look at the disease, the silent disease in the human. Beyond understanding, we heard about diagnosing, and diagnosing means not just MS or not MS, but perhaps more and more what type of MS, and what type of MS might determine what type of treatment in the future. It might be it's not one solution for all, probably. The other two goals are to help monitor this silent disease. Why? Because the symptoms are sort of the tip of the iceberg, and understanding whether underlying we have really blocked any disease process is very, very important. And so we need to monitor. And then the ultimate challenge is to predict. That's a key word in medicine. In any time you go to the doctor, you want to know two things. You want to know what will happen to me if I do nothing. That's called prognosis. And the second form of predicting is what will happen to me? Will the prognosis change if I use treatment A, B, or C? So prediction is the ultimate challenge, and it's not an easy one, but MRI, we're trying to use that. So the first thing for us is to be listening to the Scott Zamvills, the David Haflers, and the Peter Calabrese's of the world that do all this amazing fundamental science, and understand how targets, first for relapsing MS, but now for progressive MS, are changing, and then try and be inspired by that to find new MRI or other imaging markers to help them understand the disease in the human. So some examples of that are, we heard about microglia. So in the microglia world, these are the immune cells that reside in the brain. So there are specific immune cells that are in the brain. They are thought to have important roles in the origin of the disease, of certain forms of the disease, in particular progression, perhaps also in repair. And so there are some specific markers with PET imaging, positron emission tomography imaging, that can directly tie. So these are radioactive compounds that can tie in the brain to microglia, and they can be visualized by PET imaging. So this is very, very exciting work. There are a number of these ligands, these methods that have been developed. Unfortunately, PET imaging is also quite expensive. So the challenge is then to maybe use cheaper, also expensive, but cheaper MRI methods to detect this, perhaps less specifically, and so that's actually one of the projects that we are embarking on with Tarun Singhal, who has been funded by Nancy, and now I have the good fortune of being able to partner with Tarun and go from his experience with PET to my experience with MRI, and we hope that that will yield some exciting results in the not too far future. Other examples that of newer approaches to monitoring disease is looking at the thalamus, not just at the whole thalamus. So the thalamus, as perhaps many of you know, is sort of the control center of the brain. It's a hub where all the fibers from many regions in the brain converge. So it makes sense that it's very sensitive to changes in the rest of the brain, and that's what has been shown. So there are newer methods to measure not just the thalamus, but also parts of the thalamus, the so-called nuclei of the thalamus, that could yield being able to monitor differentially what's happening close to the ventricles and maybe more impacted by antibodies and B cells versus parts of the thalamus that are not in contact with the CSF, for instance. Other very timely techniques are monitoring what are called smoldering lesions. These are lesions that continue somehow to be immunologically active, and the activity is given mostly at the rim of lesions by active microglia. And with MRI, there are two techniques that are gaining more and more interest. The one is the so-called paramagnetic rim lesions. So this is using, I think we already heard about susceptibility weighted imaging from Nancy, where you can see rims of these lesions, and that's because some of these microglia contain iron that can be visualized by MRI. But one of the ways that we can use MRI for progression is a process, of course. So don't forget that repeating MRI per se is important to look at change. Even if you're not specific through detecting the exact cells that are active, you can compare one MRI to the other and look at change. And one of the techniques there is one to detect so-called slowly evolving lesions, that is based in part on work that we've done 30 years ago on these active lesions that change, with huge changes in the active phase, in the relapsing phase. But it turns out that some of these lesions in the chronic phase, years later, are still showing very subtle but very important changes that have been linked to progression of the disease. Remyelination, Peter Calabresi hopefully is making really exciting progress on how to remyelinate brains of MS patients down the road. That's very, very exciting. There are techniques such as magnetization transfer imaging that have been used for a while, diffusion tensor imaging that often are not done in the clinic, but are very, very heavily done in research, and that are promising for in the future, potentially for also for clinical monitoring. A lot of work to be done there. And finally, perhaps I want to hit another buzzword. There's so much to talk about, but there's so little time. I hope there will be some questions. We'll be happy to answer them. But AI, sometimes we don't see some of the information in the MRI, or we don't realize that some information is important. Maybe our human brain or human intelligence can't process it, but AI can find patterns that are not immediately noticeable by the human eye. And so there are more and more AI approaches that are applied to various MRI methods, including 7T MRI and others to try and predict, monitor and predict the disease. So with that, I think I'll stop, and I'm looking forward to the discussion to follow.
Thank you, Dr. Gutman. And before we move on to the fun lightning round to answer our questions, we have one last topic. That's health information technology and mental health with Dr. Adam Kaplan.
Great, thanks so much. Let me see, pull this a little closer. First of all, Dr. Calabresi, let me tell you that the PC of your initials really could stand for profoundly cool, so you don't have to worry about what you put on. Nancy, I heard just yesterday, rather than plagiarize, I'll mention it, that Ellen Mowry said her purpose in life is to lead a life with purpose. And thank you for making us all part of your life with purpose and the like. So, yes. Technology can be used to improve the doctor-patient relationship, or it can be used to replace it. So I'll try to focus on, certainly to end with the latter. And Stuart Brand, a writer, said, once technology rolls over you, if you're not part of the steamroller, you're part of the road. So my hope is to get everybody on the steamroller here. So health information technology is, as its name implies, using technology to gather information that can help people with their health. Now, we all know about telemedicine, which during COVID was a godsend for many to be able to get out. The download of applications and technology went up 38-fold during that, so everybody has had a bit. And I'm just going to hit some of the highlights in terms of artificial intelligence and using big data analytics, gathering an enormous amount of data. Hopkins and Emory were able to do this and use the data gathered from blood pressures and pulse on patients and laboratory data to predict who was going to become septic, have bacterial infection overwhelm them with a 85% accuracy 6 and 12 hours ahead of time. That's pretty amazing. In terms of mHealth applications, which is what I think most people think of, when you think of health technology, the reason being that there are over 350,000 health-related mobile applications, so good luck choosing. But that amounts to an average of 250 new apps being added every day. And the good news is that 2/3 of them are that are related to disease treatment are either for neurologic or psychiatric indications. As a psychiatrist, this is why I say good news. So that's great. The problem is, in terms of validation, only 1% of publicly available apps have actually scientific validation. So it's hard to know. You have to choose carefully and try to find people who can make recommendations. In terms of mental health applications, I can tell you that what has proved most consistently good in terms of helping with symptoms are things related to cognitive behavioral therapy. That's a type of talk therapy that gets you to sort of think about things rather than a black and white fashion, for instance, in a much more nuanced way, and to train your brain to catch you making errors that lead you down the wrong path. So that's led to between a 25 and 35% improvement in depression with Wobot. I'm just gonna name, I'm not getting paid for any of these, just to let you know what has data behind it. For anxiety, WISA, W-I-S-A, for sleep quality, Sleep.io, and for PTSD, PTSD Coach. One really cool example of technology, I thought, was that in the human breath, there are over 3,000 organic compounds, and they were able to, we know dogs can sense these things and know ahead of time what's going to happen. Well, someone got the idea of using technology to break down those 3,000 organic compounds and look, and got a breath print for people, and it ended up having a 96% accuracy at diagnosing lung cancer. So just to close, the last piece of technology is that I think real-time multidisciplinary collaborative platforms, which bring doctors together and healthcare providers together, to physical therapists and all the people that you need as part of your health, have been made and have been tested in Spain. They tested a mobile health enabled integrated care model, and they found that it had a 57% decrease in patients with COPD or heart failure in terms of unplanned visits, and 50% less hospital admission. And in Ireland, when they did similar multidisciplinary clinic approach to ALS, they had a 40% decrease in mortality, and that's, saving lives. So I really think that that's where you have not replacing healthcare providers, but actually assisting in making care better. So the last two quotes that I came across and thought were relevant is one by Sidney Harris: "The real danger is not that computers will begin to think like men, but that men will begin to think like computers." We have to be careful in what technology does. And then Elbert Hubbard, an author, said, "One machine can do the work of 50 ordinary men and women. No machine can do the work of one extraordinary man or woman." So I think, technology is here, it's here to stay, it's getting better and better. but we have to decide, are we going to use it to, help in bridging the kind of care that we want to get, or to replace doctors? And, we can talk about that over the questions and answers. So thanks very much.
Thank you, Dr. Kaplan. So now for the lightning round to answer our collected questions here. Let's just start with Nancy Sykott, Dr. Sykott.
Thank you, Claudia. So this is always a fun time. I got a bunch of questions about COVID vaccines and vaccines in general, and I think this is related to my work with the National MS Society COVID Vaccine Task Force. So one of the questions is, do I have an opinion about the COVID vaccine on MS? Yes, I have a very strong opinion. We have great data that shows that the COVID vaccines are safe, they are effective, and that people who live with MS should definitely get the vaccines, because we know that if you get COVID, that you have an increased risk of having an MS relapse. Now, not everyone who gets a vaccine feels fabulous afterward. And there was another question I had about, why are MS symptoms exacerbated after flu shot, and COVID shot? And that's because you have immune cytokines are activated. That's your immune system responding to the vaccine. So that can actually bring out some of your symptoms in MS. And this is the basis, we think, of what we call pseudo relapses. So people who live with MS who get urinary tract infection, have a fever, or even go work out, that increase in your body temperature, Euthoff's phenomena, and also these cytokines can make your symptoms worse. But they're typically not a new inflammatory event. It's just that your old lesions and old areas of inflammation are acting up. So definitely recommend being proactive if you are going to be vaccinated and you've had these issues before, that you make sure you have somebody around to help you. If you have mobility issues, take it easy and realize, usually the next 24 hours are going to be a problem. So definitely recommend that people get all the vaccines that they're eligible for, including the flu. Pneumonia, after a certain age, you are eligible for that. Definitely recommend the shingles vaccine. And now there's an RSV vaccine that has been shown also to be very safe and effective. So none of these are live vaccines. We don't recommend live vaccines for MS patients, but honestly, there are very few vaccines these days that are live, and none of these that I've talked about are. So definitely recommend that people get vaccinated. And then the other question was, very pertinent question, is there a waiting period for receiving a COVID-19 booster and taking your DMT? So it depends on your DMT. Most of them, it doesn't matter, just go get your vaccine. But the B cell depleters, so things like ocrelizumab or tuximab, ofatumumab or Kesimpta is a slightly different question. But if you're getting infusions that are being done, say, every 6 months, we know that the longer you wait after your infusion, the better your antibody response will be to the vaccine. So we typically recommend waiting at least, if you can, at least 3 months, ideally 5 months after your infusion to get your vaccine. But that's just ideally. If the vaccine is available and it's starting in the fall and you need to get your vaccine, go ahead and do it. On the other side, once you've been vaccinated, we recommend that you wait 2 to 4 weeks before you do your next infusion. And that's because of the way those drugs work. If you do it right afterward, it will negate a little bit the effect of the vaccine. Now, we do know that people on those drugs, we've learned a lot about this during the pandemic, you make less of the antibody, what we call the neutralizing antibody, but we have different arms of our immune system, as we've heard about. So your T cell responses are still excellent, and in fact, maybe even enhanced if you're on one of these B cell depleting drugs. So it's absolutely worthwhile getting the vaccine, because those T cell responses keep you from getting really sick. The antibodies hopefully keep you from getting COVID, but I think most of us know everybody pretty much has gotten COVID, even though they've been vaccinated. But the good news is, if you're vaccinated, you have less severe disease. And then also you're less likely to get long COVID. And now the other thing I would just say is that we know these newer variants that are coming through tend to be milder. And, most people who live with MS get through their COVID infection well. So that's my soapbox. Let's see. I think I talked about that. And then any studies about how the pandemic affects MS? Yes, there are a lot of studies showing there have been tremendous effects, especially in mental health. And maybe Adam could talk about this a little bit, but people who live with MS who are just isolated for long periods of time, a lot of depression, a lot of mental illness associated with that. And we're really working hard to get people back integrated into the world. And this, I think, is something that we'll continue to see impacts as we go through. Okay, I have some other things here. I'm going to answer one more. This is related to MRI. If you don't have any symptoms that relate to thoracic lesions, why aren't patients just given a full MRI, brain, C-spine, T-spine, to make sure there aren't any undetected lesions? Everyone is different and not all show signs. So absolutely, I agree 100%. In our practice at Cedars, we, for a new patient, will scan the entire neuroaxis. That includes the brain, the cervical and thoracic spinal cords. And as MRIs have gotten better, we've discovered that there are silent lesions in the spinal cord. Back in the day when I first started, the MRIs were pretty bad. And so you never really saw lesions unless somebody had a big symptom or had an attack. But nowadays we can see more subtle signs. And so we definitely do those on a regular basis, typically annually. We don't always do the thoracic cord. If there are no lesions there, then we might wait a few. Unless there are new symptoms, we won't do it every year, but maybe every 2 to 3 years. So I've taken a lot of time. I'm going to stop and we'll move on, I think, to the next one, Claudia.
Yes. Dr. Amascu.
So let's see, one of the questions is, has there been a study or conclusions on what disease modifying therapies work best on Hispanic males? So let me just start off by saying that representation of non-white populations in clinical trials has been low. This is an issue not just in MS, but in general for any type of clinical trial that's ever been undertaken. Studies have shown recently over 21,000 clinical trials studying drugs in the United States, the representation of minoritized populations was less than 20%. This is an issue in MS, like I said, where in all of disease modifying therapies that have been tested, you have about 10 to 7% representation of these populations. In many cases, probably not done intentionally, but it's an issue that, you know, for the last 20 years, we've just started realizing that MS is a global disease. MS can affect anyone, but for the decades before that, we really thought that MS was primarily a disease of individuals of white background and Northern European background. So that certainly has changed. But what we've done is that we've taken a look to see how many of these populations have been represented in the clinical trials and perform what we call post hoc analysis. And that means after the clinical trial has been conducted and ended, we look to see who was of non-white background. And so, and then we take a look to see if there was any efficacy within those individuals. It might be 20 patients, but most of the trials do indicate that there is an efficacy in those that received treatments from Tysabri, from ocrelizumab, from some of the older generation disease-modifying therapies. However, now in the current state is that there's been an initiative to try to have representation of these populations. And there is a study from Genentech called the CHIMES trial, where it's specifically focused on understanding the biology and the treatment response and safety of African-American, Black people and Hispanic people. And it just completed our first, it's going to complete the first year follow-up of 1 year. And we're looking forward to understanding how they did with ocrelizumab. What we've also learned is that most likely all of these treatments do have an efficacy. There is a thought that B-cell depleting drugs could be more effective in the Black African-American population. And that's because there is data to suggest that they have much more reactive B cells, not just in the periphery, but in the central nervous system. So we're excited to look forward at that. I also have questions here about disease-modifying therapies in patients with secondary progressive MS with no relapses. What do we recommend? Well, I mean, what we do, for example, at USC is always for our patients that are progressing, is we try to better understand if there's anything that's led to deconditioning, but also is there anything that is still active because like I said before, a lot of the disease-modifying therapies that are approved could probably have some benefit in those that are still having some type of inflammation. But in those that are not actively progressing, if they're completely not active and silent, we also sometimes even consider stopping the disease-modifying therapy depending on their age and their stability in the years before. But those that are actively progressing in respect to just progression, like independent of relapses, those are the individuals where we're talking about those unmet need and that we're hopeful with the next generation of disease-modifying therapies that are coming out. But certainly sometimes we recommend maybe obtaining some of the lipoic acid or going on even some biotin. So it all depends on the individual, what we might do. There's a question here about scoliosis. So scoliosis, could it happen in conjunction with MS, particularly severe scoliosis? Well, scoliosis is more of a bony defect in your spinal cord, and certainly that could be completely independent of multiple sclerosis. It could be where you're born with some level of scoliosis, but certainly if you have issues with ambulation and you have scoliosis, well, that's probably going to just, have greater effect in your back and your ability to walk. So the fast answer for that is not necessarily caused by MS, but completely separate. And I think that's about it for now. Yep.
Thank you. Dr. Kaplan.
Great, thanks. So the question here is, aside from, sorry, there's 4 questions here, so trying to find one. Aside from the difficulties of dealing with disability, why is the correlation with MS and depression so high? This is near and dear to my heart as a psychiatrist dealing with MS. And what I can tell you is it turns out that depression is a disease which is often caused about 60% of the time by inflammation. There are other ways you can get it, drug use, hypothyroidism and the like. But when people have looked at people with depression, 60% of the time they have markers of inflammation. We know that that's important because it turns out all of our antidepressants are anti-inflammatories. And in a study that put people with MS on who were not depressed on Prozac versus a placebo, those on Prozac had fewer lesions. I'm not saying that these are as good as disease-modifying therapies. We live in an amazing time now where these disease-modifying therapies are profoundly effective for many aspects of the relapsing remitting variety, but MS does cause depression. Depression is a risk factor for getting MS, so don't ignore it. You need to treat it. And the good news is that of the things that MS causes, fatigue, cognitive impairment, bowel bladder, well, you name it. Depression is one of the more treatable versions where we would expect to get someone all the way well with treatment. So don't miss the opportunity to get treated. Let me see if I can enlist the help of Dr. Calabrese for this question. The question is, what is the best way of delivering the diagnosis of MS to patients? Are you there, Dr. Calabrese?
I am. Can you hear me?
Yep.
Yeah, great. So never something that I like to do, but of course it's what we do. I would say that it should be done face to face and not over the phone. You hear stories like that, which is never good. Ideally, the person who you're diagnosing also might have a friend or a family member, because many people freeze up when they hear bad medical news and don't retain a lot of the information. So it's really helpful to have someone else to listen and take notes. What I tell them is what you just said, that if one has to have a disease like MS, now is probably the best time, because we have over 23 therapies and there's a lot that can be done. I make sure I give a very detailed explanation of the fact that MS is an incredibly heterogeneous disease, and that some people can go 40 years with relatively little disability, but that it's a disease that we take seriously and needs to be monitored carefully. As Nancy said, second opinions, third opinions are a good idea and always welcome. More smart minds, the better. And I always tell people I'm not going to be offended. Go talk to someone else. And I give them names all over the country. There are lots of really smart people who take care of people with MS. But the future is bright, and I think it's a disease that we are, as Howard Weiner said, we are curing. There are some people who have been in long-term remission on the high efficacy monoclonal antibody therapies that we have, and there's unfortunately still some people who elude us, but I'm optimistic that we're going to have better treatments moving forward. So that's how I handle it.
Thanks very much. Dr. Hafler, I was wondering if you might help with a question. Has there been any new studies to cure MS involving artificial intelligence or the applications of sort of big data analysis? Is that something you could help us with?
I think the answer is no.
Okay.
I think artificial intelligence, I think, can be very useful in a number of veins in terms of analyzing data that being generated. But, you know, getting to the cure of MS, something that hasn't been brought up yet, but maybe worth discussing, is EBV, the Epstein-Barr virus, and a lot of discussion about that. And we had this discussion yesterday at our symposia. Getting to Nancy's question is, how do we cure the disease? So many of us feel, at least I feel, that there is good evidence that Epstein-Barr virus, which affects 93% of the general population, 100% of patients with MS, may well be the trigger of the disease. It may trigger and then disappear, or may be persistent. And one of the experiments that we all in society is considering is vaccination against Epstein-Barr virus, particularly in individuals with high genetic risk for MS, first-degree relatives, or potentially individuals who have a high genetic risk score. And that would be the key experiment, because if it's true that the EBV virus, the Epstein-Barr virus, is what's leading to that break in tolerance, loss of immune regulation I spoke about earlier, maybe the way we can really cure MS is to prevent it by preventing the virus in a genetically susceptible individual from starting the disease. So rather than thinking about artificial intelligence, which is talked about a lot, I don't know where that's going to go. I like to think about real things, and both Moderna and GSK, GlaxoSmithKline, are getting ready to start clinical trials with an Epstein-Barr virus vaccination, and we're in discussions, at least with GSK, about having an arm that includes patients at risk for MS to see if we can prevent the disease. So that's where I'd like to put my efforts right now.
I wonder if I can jump in here, because I had a question that I wanted to actually ask Dr. Hafler. It was a vaccine question, but a little bit different. So this was a question, curious if anyone has thoughts on the study out of Chicago on the inverse vaccine and how they see this potentially helping in the future. So this was the antigen-specific vaccine, or a T-cell treatment. You know what I'm talking about, David?
I know exactly what you're talking about.
Okay. So I thought maybe you could comment on this, since you had talked about cellular therapies already.
Yeah, I was a bit dismayed over the press release from the University of Chicago. Many of us, let me just state that, you know, we think MS may be caused by autoreactive T cells. We and just so many other individuals have tried to turn off that response, and in MS and other autoimmune diseases, and to date, none of us have succeeded. And there are technical reasons why that may be the case. I thought it was a cute experiment they did, and once again, we cured MS in a mouse, but I do not think those experiments will directly lead to any viable treatment in patients with MS. And I can go into the technical reasons why I think that might be the case, but I was a bit disappointed how they overhyped this in an animal model. So what they did was basically they induced inflammation in the brain in the mouse by injecting a particular myelin protein, and then they turn off the response to that protein and stop the disease. And that's been done over and over again by many different laboratories. The trouble is that once you start this inflammatory response, within weeks, you begin getting spreading so that there are multiple self-antigens that are there. And they didn't do the key experiments, which likely would not work, where if you turned off the response to one self-antigen, we prevent the response to others. So I don't see much coming from those experiments. Maybe Peter wants to comment also.
I completely agree with you, David. It was disappointing the way it was billed as a MS-like disease. It's frustrating because we're all trying to be positive here, but it doesn't help, and it raises false hopes. So.
Ditto.
Yeah.
There was nothing novel at all. It was really disappointing that they promoted that. On the other hand, David, do you want to comment about an inverse vaccine to a CNS autoantigen, like what the people did in Europe? The Moderna type approach. Any thoughts on that?
The RNA vaccines, well, I think it's the same issue. As you know, Howard Weiner and I tried oral tolerance, where we took antigens, and the idea was to induce what we call bystander suppression, where we were able to target suppressor cells that went directly to the brain that would stop any inflammation. And unfortunately, those experiments in phase 3 studies didn't work. I think the RNA vaccine, it's the same basic issue, that if you induce the disease in the animal model, and Scott, this is your area, with one protein, and if you tolerize to that protein, yeah, you're going to stop the disease, but that's not what the human disease is about. So I think, to me, the best approach, the epidemiologic data from Alberto Esquero from Harvard, it is so compelling. I think that's where a lot of the efforts need to be in terms of stopping the disease, whether EBV is persistent in some fashion, which continues which drives the disease. And we just received a innovation grant from the center to directly investigate this in patients with new onset MS. We've looked very hard for EBV infection in the disease. We just had evidence that the virus was there, but no evidence of active infection. But we've looked in blood and the nervous system, and the virus doesn't live there. The virus lives in the nasal pharynx, in the tonsils, and in the back of the nose. So we're directly examining those tissues. Just last week, just on Friday, new onset patient did a SPONTAP and the biopsy of the tonsils, and we're doing analysis looking for the virus there. So we're trying to find evidence for active viral infection. If we do, then that may be something that we can actually target. So that is the avenue that, at least I personally think, can be most productive.
Thank you. And Dr. Yadav, I think you have some questions to answer.
Sure, thanks, Claudia. So I have several questions on exercise. I'm just going to summarize at least 3 or 4 questions in one theme here. So one was a question about correlation between exercise and mobility in MS. What level of exercise is necessary? Then discussing cardiovascular exercise for MS patients, and what is the perfect exercise for MS looks like. So in general, what I would recommend is before you jump into exercise, make sure the mobility is not affected by some other cause. For example, many patients with MS will have issues with knees and hip, and like having knee pain and hip pain can actually directly impact your mobility, and then you're blaming it on MS. Okay, so the first thing is to make sure you rule that out. And if you rule that out and then you think that weakness, or the doctors think that weakness is the only cause of your mobility impairment, definitely work with the rehab doctors or rehab specialists like physical therapists and understand which muscles are weaker, which needs to be strengthened, because there's a lot of there's an imbalance of the muscle weakness, like the group of muscles which are allowing us to stand up and walk and sit down and all. They're different group of muscles, and there can be imbalance of those groups of muscles. So working with the physical therapy is the best way. And after you learn those techniques with the physical therapist, then you start working with a trainer if you can, or learn those techniques and time again with a therapist. Because I think exercise under guidance is the most important, I think, part of your rehab. If you do not really do it right, you can actually harm yourself. And then the next question is, what kind of exercise is good for you? So there's no, I mean, after you figure out like which group of muscles need to be improved upon, the next set of think or thought process should be what you enjoy the most. Like, once you have worked on those group of muscles, do or come up with a regimen which you enjoy the most. And it can be anything. It can be yoga, it can be water aerobics, it can be like walking, it can be any combination of things, but you have to improve your cardiovascular capacity. So if you're not really improving your, what we call VO2 max, I think most likely you're not getting as much benefit as you can get. Once you start improving, once you start increasing the level of activity, and to tell you the truth, people who are sitting in wheelchairs also can improve their VO2 max. So doing weights, if the hands are not really paralyzed, you can use weights to improve your capacity. So working with a trainer, working with the right experts is really, I think, the best way to do it. And all those things are available actually through insurance. They are available now. So make sure you utilize those resources. Another question is, the other thing is amount of exercise that you need. So anything from 3 to 5 days a week of a moderate level exercise is considered good. Even if you can just do 10 minutes of short, like total of 30 minutes, and you can divide that into 10 minutes of each with moderate level, that can be sufficient. So I think small steps count towards the big goal, but the key is consistency and enjoy whatever you're doing. It should not be forced upon you. So that's first part. The second thing is, second question was that a person who's in wheelchair, and if there are any medication that can help regain some of the strength. So unfortunately, there's no medication that can help, with walking. There was one medication called Ampera or dalfampridine, which is approved by the FDA for improving walking, but that's not for people in wheelchair typically. That's for people who are still able to walk, and it can improve your walking fatigue to some extent. But again, personally, I feel if you are exercising enough, you can actually gain some of the function rather than the medication. So I think pill necessarily is not the answer, but working on your body to improve, your overall muscle strength is really critical. Sarcopenia is another term that I think most people don't really pay attention to. Sarcopenia means loss of muscle tissue with aging, or with inability, with the loss of mobility, or loss of activity. That's a real issue which impacts anybody. All of us will undergo sarcopenia if we're not really moving enough as we age, and aging people will have faster rate of sarcopenia. So that's something to keep in mind, that you make sure you keep moving, even though as we are getting older, we should not really be limiting our physical capacity or physical activity. Really important concept. Another question was about somebody's having involuntary hand jerking, and is there any drug or physical therapy that can improve that? So the important thing here is, what is the cause of hand jerking? MS can cause hand jerking, but at the same time, you also want to make sure the doctors have evaluated you for other causes of hand jerking. So there are medication that can help to some extent, but many times, working with occupational therapists can be helpful in improving the hand function, which is affected by the jerking. We also have a specialty within neurology called movement disorder specialty. They are the expert in this kind of, a disease state. So working with them can also be helpful. There are some newer technology-based devices which are available for improving hand jerking, but I would say I would recommend working with a movement disorder specialist is the way to do that if you're not able to get help from the general neurologist. I think then switching gears, Some questions were on the dietary supplements as well as diet in general, what kind of diet one should be taking, or the dietary implications. So when I talk about diet, I think now I'm switching more towards nutrition versus diet, because diet is not equal to nutrition. What we need to do is nourish our body, but not just eat whatever, like, some fad diet that are told, which is like a short-lived kind of approach. That's not healthy. What you need to do, or all of us need to do, is focus on a dietary intake which is nourishing our body. Really important for MS patients as well. And, again, I do not want to talk too much about that, but there's no one diet that has been proven for MS. There are multiple dietary approaches which have been tested. Many of them have actually shown to be helpful in improving quality of life. Includes fatigue improvement significantly. Our group has done a lot of work on low-fat diet. I'm not saying like low-fat diet is the way to go, but low fat can, again, within like a 3-month interval or 1-year interval, can change your fatigue. But is that the long-term beneficial effect to you? Not sure about that. So work with your doctors about right nutrition. If you have access to nutritionist or dietitian, absolutely use that resource, because I think they can really teach you how to stay healthy, how to eat healthy and nourish your body well. So again, no one diet that works, but working with your, and plus, people can have deficiencies. One of the deficiencies which is very common in, two deficiencies which are very common in MS patients or in general population are vitamin D deficiency, and in women, iron deficiency. So those two things, and people who are complaining of fatigue, especially fatigue, as more than 70% of people can have fatigue. You have to get to the bottom of what is causing fatigue. MS is not the cause of fatigue in everybody. They can be hidden cases of iron deficiency or vitamin D deficiency, something else, which is causing fatigue. So make sure that you are addressing that with your primary care doctor. Address those. I've seen many cases of long-standing iron deficiency, which went unrecognized, and then once they started supplementing, that improved significantly. So focus with, work with your primary care doctors on those kind of issues. In terms of dietary supplements in general, I think a daily vitamin supplementation or multivitamin is probably okay, because it's very difficult for everybody to eat like the healthiest diet every day, 3 times a day kind of thing. So I think having a daily vitamin is okay. But there's no one dietary supplement that I can tell has been proven for MS. Multiple things have been tested. We are looking at antioxidants. We have looked at lipoic acid. We are not currently recommending that we take that, because even supplements can have side effects. So every supplement is a chemical product. You should not be taking it without kind of consultation with the doctors. So the data which is published does not mean that is ultimate data. You need to have longer term data, and this is what is difficult to get. So be mindful of taking supplements. That supplements can cause danger as well. And I think one more thing I would like to address here is diet and obesity are really, diets, actually lifestyle and obesity are really big, hot topics, like, in MS and in general currently. And we have new drugs for obesity, which are really effective, which can cause weight loss, but they all come with side effects too. So if anybody is working on, especially people in menopausal women, especially as you start to change your metabolism, you can gain quite a bit of unwanted weight. Work with your doctor to choose the right medication for you, and for weight loss I'm talking about, because BMI and fatigue, they are also correlated. So BMI is body mass index, an indirect measure of your obesity. So that has to be addressed as well. And all of these factors, can impact MS adversely, just like it can affect general health. So something to really keep in mind as well. And the very last question was about should women take bioidentical hormone replacement to impact MS in a positive way? I think I would say work with your primary care doctor, and if they feel that the hormone replacement treatment is the right choice for you, you should go with that recommendations. I'm not sure, at least in our field, there's a lot of research going on about the benefits of hormone replacement therapy, both for estrogen as well as just, but I think we do not really have final answer yet. So I think whatever has been proven in general health, general gynecological health, I think that's what you should be following recommendations by. I think that's just my personal opinion. I think with that, I will finish.
Yes, Dr. Zambil.
Sure. Let me just begin with reiterating what our colleague, Dr. Hafler, had to say about work in mice. And just so that you're aware, really caution when you hear press releases from work from the animal models because they don't always translate. And that was a really, good example. I have devoted most of my career. I work in mouse models. I also work with patients as well and human. And I would just say I feel guilty because I feel like I'm a magician, and I can make certain things work in mice. And that's it. I have the tricks. It's not a good feeling. You don't translate the magnitude of an effect on a therapy from a mouse to a human. The mice are important because you can address mechanistic questions. On to a more serious point here. One of the questions that I had is a patient, I'm on Kesimpta. Patient could be on rituximab, could be on Ocrevus, and I have no disability. Will I transition to progressive MS? I can't answer that. That's a difficult question. There are many factors that go into that. I would say that thinking my knee-jerk responses, I don't know age, I don't know gender, I don't know the CSF findings that you have when you were diagnosed with MS. And all of these factors go into predictive values of going on to progression, comorbidities. But built into that question is, do I remain on my therapy if I'm stable? And in general, that answer is yes. For most of us, I have examples in my own practice, I guess, at UCSF, where I have patients that were on Copaxone and stable without any new lesions and new disability, and they were in their late 60s, and I took them off. One had a flare 6 months later, and another had a new enhancing lesion. So that's one of the things. But we do pay attention, especially on the B-cell depleting therapies, that we monitor antibody levels, the IgG levels. We need to know what other potential reasons for immune suppression you may have. So we can't answer the particular question. It's a little bit too complicated. The second question that I had to do with what therapies are available to counteract brain and spinal cord atrophy, or what therapies are available and on the horizon. I'm not a neuroimaging expert. We have two in the audience, and I would say that from my background, is that when we look at our established therapies, we've always, for 20 years, looked at measures of atrophy and have found that even the medications that we have now that we've used, even something like Copaxone, there's evidence that it reduces accumulation of atrophy. But these medications are mostly anti-inflammatory. What we're speaking to now is neuroprotective medications. That isn't to say that Tecfidera, which is antioxidative, is acting through just an anti-inflammatory mechanism, but also has some potential neuroprotection. That was a theory that was used to advance that medication to clinical trials. What are the ones on horizon? Well, you've heard about a couple of those already. What might be coming? Some of the oral therapies, the BTK inhibitors might be. You heard about alpha lipoic acid, OHSU, in their group, and other medications, N-acetylcysteine, which actually is kind of a sump for oxidative compounds. So there are hopes that we will have other therapies. These are just a few of those to mention. And then I'm just going to close on a little lighter note. Dr. Calabrese, are you on? I hope you are. And I would just want to say this gentleman in the front row to my left or the far right there as a reminder. Blue is cool in Southern California, but if you come to visit us in Northern California, there's another combination that works pretty well. You can wear orange and black.
Good to hear.
Thank you, Dr.
Roger.
Sample. We're getting close to the end of answering our questions. I think that Dr. Gutman has a couple of questions and then we'll wrap it up after that.
So during the next 2 hours, no, I'm joking. You are lucky. I think I can be relatively short and sweet. I have 3 questions. The first one is, when is a study for males with MS using 7 Tesla MRIs and their progression going to be done? So you heard from Dr. Sikot about the NAMES Consortium, and the NAMES Consortium has a working group of centers that use 7 Tesla MRI, and they have ganged together, I believe also with the gentle prodding of Nancy. I don't know where they're at. They have, I know that they are quite active, and I don't know about specifically a study being done on men. I think that both genders are being looked at, including men. And I would say from our own center, Drs. Rohit Bakshi and John Zuravsky have been systematically acquiring now for years 7 Tesla MRIs, and I believe that currently we have at least 400 MRIs, I believe, so in 400 patients, some of them over years, so longitudinally as well, and they have made quite a bit of strides in identifying some innovative biomarkers, which takes me to the second question. Are you looking at gray matter in the brain? I assume that wasn't meant specifically for me, you plural, but my team has looked in the past at cortical lesions, for instance, and to look at cortical lesions, that means damage to or around the gray matter on the surface of the brain. It has been quite challenging, but a lot of progress has been made over the years. One particular sequence that has been evaluated quite a bit is the dual inversion recovery sequence, which recently we have supported a multi-center study that was published in the journal Radiology with a sort of a center, our Center Without Walls, which is a collaborative web-based platform that was used to do this. Little plug for collaboration that I know Nancy really is also supporting. I spoke before about looking at the thalamus, the hub of the brain, if you so will, and looking at different parts, different nuclei. Those are gray matter nuclei of the thalamus. So yes, both at the cortical level and at the so-called subcortical level, ourselves and others are very intensely looking at gray matter in the brain. Finally, and here, Nancy, I will need your help. I am a researcher. I'm talking about Nancy Sikot now. Just to be clear for this particular question.
All right.
Yeah.
Yes.
So I studied medicine a long time ago, too long ago. I'm not licensed to practice in this country, so all the disclaimers done. And I'm not active, in clinical practice. I do research. But the question is the following. Should MS patients get dye during MRIs? Is there any long-term downsides to doing the dye? Now, I have been part of recommendations from a French consortium called OFCEP. And the short of it is that over the years, early on, about 30 years ago, dyes, gadolinium-based dyes were administered very frequently. I believe that in general, the use of these dyes has been reduced, but nevertheless, they remain useful in certain situations when certain specific questions are done. And again, I will let Nancy Sikot expand on this. In terms of long-term downsides, much has been made about the fact that MRI can demonstrate accumulation of the dye in the brain. However, to my knowledge, that has not been, fortunately, so far has not been associated with symptoms, but I'll let you, Nancy, please comment
You
further.
did a beautiful job. And I'll just add that in practice now, previously every scan, we would give gadolinium looking for evidence of new lesions. Now that we have good, high quality imaging that we can use as a basis, as long as we have a baseline to use and there are no symptoms, our practice now is that we don't give gadolinium. We definitely use it in a setting where there's a new symptom and we're trying to evaluate whether there's acute inflammation. So it still has a use. And for someone who's had very active disease and we want to see that it's resolved, we will sometimes use it. But I think most of us are using a lot less. It's less expensive because the gadolinium itself adds at least $100 to the scan. And then because of these theoretical concerns, I will also agree with Dr. Gutman that we have not seen long-term consequences, but you can see changes on imaging, actually, that some of this gadolinium has deposited in the brain. But the other thing to be aware of is the newer versions of gadolinium now are much, much less likely to have this effect. It turned out that the older versions were disassociating, the gadolinium was coming off, but now the new forms of that don't do that. So you should feel very safe if you are doing a contrast study. It's very safe. There's been billions of doses of gadolinium given across the globe. And so if it's indicated, it's the right thing to do. And while I have the mic, I'm going to answer one lingering question that I had here just to sort of make a pitch. The question was, how can I learn about MS research opportunities? And this was specifically estriol research at UCLA and institutions across the country. And I just want to make a pitch for people participating in research. And as we heard from Dr. Amezcua, especially people who traditionally are not involved in research, I would say the best resource would be clinicaltrials.gov. And that is an NIH-based site where pretty much all of the studies that are going on are registered there. And this is a way to keep track of the research that's going on. And you can search that for MS or for other specific areas that you're interested in. You can search it for your geographic location and so forth. So definitely recommend taking a look at that. Also other MS Society for things that they fund is there, and the Race to Erase MS as a website also. So I definitely want to encourage people to get involved in clinical trials. So, and that's all.
Thank you,
I-
doctors.
May I just take the word just one last moment, just because I want to pass the buck, I think one says, to Dr. Amezcua, because it's on my little strip of paper here, but it's, oh, you answered that one.
On clinical
Just wanted
trials.
to make sure I didn't want to leave any questions unanswered.
Thank you. Thank you, doctors, and thank you all for being here. And I'm going to let Nancy conclude this.
Okay, thank you, Claudia. You're amazing. Claudia has been doing this since the very first Race to Erase MS 31 years ago. So Claudia, thank you for everything. She is definitely a rock star and amazing. So we love her, as are all of the doctors and everybody here today. It's really interesting to hear what everyone's saying. The latest research, the questions are super important to answer, and so glad to be, with this esteemed group of doctors. I mean, all of you guys are so brilliant, and your research takes you in so many different areas, and it seems like we're covering a wide breadth of very important issues and things people are dealing with. So I'm so grateful that we are here today, and we look forward to doing this again. May 10th, we will have Race to Erase MS, and May 11th, we will be probably in the same exact room here, same time. So put it on your calendars. Hope you can all attend the Race to Erase MS, and thank you for being here. Thank you for supporting us. And, we're really passionate about finding a cure for MS. So we're in, as Dr. Hafler said, we're not doing this slowly. We are in a race to erase MS. We want to hurry up and make this happen and prolong any suffering and do the best that we possibly can. So thank you for helping us achieve this super important goal.